Good morning. We're just waiting for the people that are starting to come in as we prepare for our second Latin America and the Caribbean program. So we have a lot of nice cases today, and um, I think that for me, I'm most excited because it's the second time around. Like you only show that you are serious when you come back. So here we are with our second program for Latin America. We have already completed two for Africa. We've already gone to Asia. Um, so this is going to be our fifth case competition. I'm here with our co-director. Is that how we said it? Farouk, why don't you get us started?
Sure. We're just watching people trickle in. We're here in the control room with a lot of people that make it happen who you get to meet as the day goes on. Excited to be back here doing this again. This is a tradition that we do about every 3 months. We move around to a different part of the world. And we're back, like Hansel said, to Latin America and the Caribbean to make it happen again. The cases are even more exciting. The energy level is even higher. So I think we're gonna have a great day. Should we go ahead and get started, Hansel?
Sure. So first, quick thank you and introduction to the team. We have Yarel Mequete, that is our manager. And then we have as one of our judges, as we go around the table, I'll show you the table in a minute, Dr. Abbas Noor, like, that is judging as always. And then we have Luis Tierra Adentro, Mónica Miranda, and Laura de León, that are our research fellows here at the Children's Hospital of Philadelphia, and they help us organize, and they're going to be hosting, they're going to be presenting each of the cases. Dr. Mohammed is going to be in the controls, and then is kind of from far but not that far away, we have Alejo Carvajal from the Center for Global Health, and Herman Derby, that is our research fellow. So that is going to be the team. You will see our face. You'll see our faces as we go through. Our guest judge also joining us from home is going to be Dr. Estefania Cajigas, from originally from Puerto Rico, but one of our interventional attendings here at the Children's Hospital of Philadelphia. I just want to say before we start that it's been really nice receiving all the cases from all the different countries. A big shout out to the countries that didn't participate before, and now we received their best cases. And I'm looking at you from Honduras and Chile, and also big shout out to our friends in the program from Guyana. Like all those are new competitors. Their cases were awesome, and we'll see some of the good work that they're doing. With No, we'll do that at the end. We'll thank our bosses. Right now, it's about getting us started. So let's get started. We're gonna start actually today with. I want to introduce you a personal friend of mine, Dr. Carlos Ugas from Lima, Peru. Um, he is a force of nature. Like he has been working so hard to get pediatric radiology the attention that it deserves in a country like Peru, and they have a great team at the Instituto del Niño San Borjas in Lima, and they are putting together so much material, so much content, producing so much research that I really wanted him to be here with us and share a little bit. Just to give you an idea of the all the things that he's doing. He is the director for diagnostic services at his hospital, which means that he's not only in charge of radiology, but also laboratory and others. Like whatever you use to diagnose, like this is your guy. This is Dr. House, so to speak. And then he's also the founder of the newly founded Innovation Lab at his university, and that's why he's going to be talking to us today. So welcome, Carlos, and please take it over.
Thank you so much to all the team to do this again, and I guess there will be a great success. And I'm very happy this morning because I want to share a little bit of my experience into issues that I really love, teaching and research. So the name of this lecture is Advancing Pediatric Radiology, Teaching and Research, the road ahead. So I will talk about my experience to how to face a difficult setting for these two topics, and also from my point of view and with the help of la Sociedad Latinoamericana de Radiología Pediátrica, the SLAR, I think that we make some difference for advanced medicine and our specialty. So this lecture is from my point of view, so let's start. Let's go back to 2013. This year was very important for me because my hospital was new and was open. So I'm here. I can use this pointer. And here, younger and naive, and this is the whole medical team. We were few physicians, and we start with a lot of dreams. So what happens of pediatric radiology again? How was the situation of the pediatric radiology in my country 10 years ago? So yes, we have this beautiful new hospital, but there wasn't no publication in pediatric radiology journal, and for be real, very scarce publication. We don't have at this time international internship, no fellowship, and the representation of my country in the international meeting was really scarce. What happened right now in teaching? We had a list for residents in my department, and also we have an international internship, and we began last year with people from Ecuador, Bolivia, and there are other countries who will came here soon. And also we have the subspecialty of pediatric radiology approved for the Ministry of Health, and will be start this year or maybe next year, but we are very happy about this. And also we passed from 0 to have a, I guess it's important number because it was very difficult to get to this point. And by this time we had 7 original papers in Pediatric Radiology Journal, and we are looking for more. How do we do? So today I will talk how we do that. In my point of view, my experience, as my friend Hansel said, I had a lot of help from my team, which is a very outstanding team, and also from the SLAR, which is also a very huge human capital, help us always. So today I will talk about these two topics: how to improve teaching, and with some experience without any cost, and also a roadmap to start publishing in highly indexed journals. Let's talk first about teaching. Teaching is key to advance all the medicine in our specialty. And first of all, I wanted to remind the residents' role at the hospital is learning. Sometimes this is forgotten in our country because we had a heavy workload, but residents are not a cheap workforce. Residents has the only and sometimes the only one opportunity to learn in these years. So it's very important for them to focus on learning. And for us, one part that is very important, one component that is very important is to have a structured program. So we have a structured program, and this was a product of a teamwork for the most experienced specialist. Also, this program must be achievable. It's different to have a resident for 1 month, for 2 months, or a fellowship. Also, this must be updated at least 2 or 3 years, every 2 or 3 years. And this topic is very important to include radiology protection. Sometimes in our countries, this is forget that is not a part of our job, but it's a key part of our job. Also, it's very important to have continuous academic activities. We have continuous academic activities, lectures that are given for the staff of radiologists, of pediatric radiologists, and also every month we have 1 or 2 foreign pediatric radiology. That is a lot of fun, and we learn a lot in these activities. For these activities, also it's very important our SLAR networking. So we have outstanding, great friends and great teachers who gave us beautiful lectures, and we always have this really nice support. Also, we have a virtual classroom and a YouTube channel where you can search for every one of the lectures that are there. So let's talk about research, which is very important. Why is important research? All of us live the pandemic, so without all the research of the vaccine, of the treatment, there will be more deaths. So research saves lives. And also another thing that I learned is that research improves procedures, improves the quality of our procedures. To publish in a very important journal, you have to follow all the steps that are supposed to do, and sometimes I miss it in our country. So it's very important to start research for these 2 main reasons. So to start this is important also to start little by little. So look for small trends. For example, you can start with a case report, tutorial review, case series, or technical innovation before you start a clinical trial or something like that. So it's very important to go little by little and look for support. And you must go to your institutional research department, or if you don't have this support and you are associated to the SLAR, you can contact us. We in SLAR have this mail. You have research using that you have a manuscript, and the manuscript is like complete for you. We can help you. We can help you. So let's contact us. Another important key for success is mentorship. So the mentor had a lot of work to do. First of all, have to share the knowledge to the trainees, also overseeing their advances, and also to connect to another researchers. So I had a lot of these mentors who helped me, who inspired me. Here is Monica Eppelman. She's always with us. And this is so important and you can also look for mentors in your institution. This is very important. So I really love this part, the steps to getting a scientific publication. To start a publication is, well, sometimes it's really challenging, but what you have to say, first of all, is to have a good research question. And a good research question must be feasible, interesting, novel, ethical, and relevant. So it's very important to define a good question. To start all over is very important. First of all, to start a good question. And as any other human activity, is very important, the team. The team is also a key for success. This team must be diverse as possible. And you know that all the health questions are challenging, and to have a different point of view is always good. And they might be motivated because research is not easy, it's not fast. They may be motivated. Also, it's very important for the very first day, they define the order of appearance. It's very important to define the orders of appearance in the papers since the very first day. Sometimes in Latin America, we say, oh, no, for me, it's okay to be second, third, or the last. But it's very important to define this. I learned this, and this is very important tip for you. Another very important tip for you is to choose a right deadline. To defeat procrastination, it's very important to measure your performance and productivity, and to have a smart deadline that doesn't have to be so short for you to feel stressed, or so long for you don't do anything. So it's very important to choose a very smart deadline. And talking about the protocol sometimes is the challenging part for the beginners. So what do you have to do? What you have to do is to follow your institutional guidelines. Follow your institutional guidelines, like cook recipe, something like that. All the items you have to fill, try to do that. And if this study needs IRB approval, let's go for this. And it's very important to keep the background simple. I know a lot of beginners who try to put everything in the background. The most important part for a protocol is not the background. The most important part for a protocol is a good question and detailed materials and methods. So as a summary, well, after you finish your protocol, you start your research, and then you have your IRB approval. Then you start to write your manuscript. So your manuscript has to have an abstract, and the abstract must be perfect. The abstract is the presentation, is the face of your research. So it must be perfect. Sometimes the decision to publish or not to publish is based on the abstract, so this must be perfect. The introduction, again, must be brief, and material methods, again, must be detailed. And we are radiologists, so features must be demonstrative of the pathology that we want to share. So never use these word compositions. Sometimes we use word composition of different patients or different views that are kind of difficult to understand. So it's better to use just one image for each patient, for example, one modality, or no more than two. So it's better to be very straight to the point with the figures. Also, to do the presentation of the result in a logical term. So also it's very important this, and for the discussion to be focused, and to don't look for strange things, just what you are researching. And also we try to forget this, but all the study has limitations, so try to be sincere as possible. Try to be detailed also as possible. It's very important for the reviewers that you are aware of your limitations. And finally, you have to do the conclusion, and the conclusion must be the result of all the manuscript, must be the result of your results of all the things that you really find. So don't look for strange conclusions or something that you are thinking. Just be objective. For the process of submission, it's very important. The most important thing is to be calm, to be relaxed, and do it with calm. Sometimes I use this, for example, one night when I feel relaxed, or Sunday at the morning, I feel relaxed, kind of. And it's very important to attach a nice cover letter that justify what that says why it's important my research, what is relevant to my country, for example. You can do that, it's very important. And also, it's super important, check the order. I miss sometimes, I miss once the number of figures. Sometimes you have like 20 figures and you put A, B, 1B, 1C, 1F. This is kind of crazy. So try to be calm to check the order. It's very important. And they will look that you are really serious, really detailed. You had a good work. You do this with order. And to answer the reviewers, well, my friend Hansel teach me this phrase, which is magic, done and suggested. So why do we have to fight with the reviewers? They want a reference and they want a word to change, but they don't change the spirit of the research. Let's do that. What we want to do is to publish, not to fight with the reviewers. And most of the time, almost all of the time, the feedback is positive. So it's okay, it's good. Try to do what they ask to do. Always be really polite, careful, and sincere. If you don't have some data they want, you have to say, in my country, we don't have the data, we don't used to register the data. So it's very important to be very sincere. And when, well, we have just a few minutes to talk about the road ahead. And I will talk about the road ahead in the point of view of my hospital, but especially in the point of view of this lab. Well, yes, about the gap that we have still in my country, but in all Latin America. So talking about the number of pediatric radiology, the gap between the high-income countries and our countries is like huge. This map is dramatic, but if we had a map talking about the capital cities and the small town or the rural areas of Latin America, will be like more dramatic. So we have very few pediatric radiology, and all of the pediatric radiology are in the bigger cities of our region. So there is very important to help the others, to help general radiologists, pediatricians, or whichever are in charge of the children care. And we have this beautiful experience last year with the help of World Federation of Pediatric Imaging and SLAR in Misiones Argentina, like technology transfer, something like that. So specialists in ultrasound, in pediatric ultrasound, go to this small town and they help pediatricians, general radiology. So this kind of experience can make the difference. So I think that that will be very important part to do in the future in all over Latin America. Also, we take advantages for the virtuality right now. So last year we had a MRI course, and thank you to a lot of guys that are also in the United States. And with the help of SLAB, we do this course. And this year we have a new course that will start next month. That will start next month, and we'll talk about ultrasound, CT. So you are very invited. And well, I really want to talk about radio protection. And I am working right now with Lina Cadavid and other researchers for Latin America. And our goal was to define the level of reference for CT, in the level of reference of dose in CT for pediatric CT, especially from head, thorax, and abdomen CT. So, as a spoiler, what do we find? Well, we found that the level of the radiation, the level of radiation in our countries are huge, are like 4 to 7 times the level of reference used in Europe and the United States. So it's very important, again, to keep in your minds that for radiologists, one important part of our job is, yes, do the diagnosis, do the interventional radiology, but all the time think in radio protection. And to improve research, for example, Europeans always do this beautiful multi-center study. We can do that also from the slide, and we had already do that with COVID. Was a really nice experience, and right now with this reference dose for CT. So we can use this beautiful human capital to promote multi-center study. SLAR will help you with this. And also we are offering a mentorship from the hospital and also from the SLAR, because it's, again, a key way to do the success in research. And yes, it's very important promoting contests like that we are doing right now, especially to include the residents that are the future of the pediatric radiology and all the medicine. So finally, I want you to take these home messages. So there are achievable changes in teaching. So they don't require like a lot of money to invest. Just require some kind of sport and creativity. For example, our YouTube channel is free, and you can join this. The part of the research is not easy, is not fast, but it must be guided with perseverance and teamwork. And it's very important to be aware that you start and you need a guide. So it's very important to look for strategic allies, mentorship, and this life. As the famous poet in my country says, he is César Vallejo, the famous poet of my country from Peru. Hay hermanos, muchísimo que hacer. Thank you so much.
All right. Thank you, Carlos, very much. That was awesome. Like, and I identify a lot of the things that we've been doing, and I know that we've been working together in some of these issues. And it's, you know, through CHOP, through the WFPI, through the SLARP, like we're all trying to do the same, like trying to grow that academic community in Latin America, making sure that people feel supported and feel, you know, like they can look up to other people and ask for help and you know, get added up to this community. That also I gotta say is aside from the academic rewards, is like all these groups are just made of amazing people, and it's just really nice to be part of the family. No? If anyone in the audience has any questions, of course, you can always put in the chat. I think that I have one question for you that I think is on people's mind. That is, how much support, and when I talk about support, I mean probably money, do you need from your hospital to start these all these programs? Like, is this something that you start kind of on your time off, or is this something that you actually require your boss to tell you, like, oh, you have this time to do it?
Well, first of all, I think that it's very important that political decision in your hospital. For example, I'm very happy that my hospital is looking to have more research, more quality in teaching. So we have, for example, hours for research that I think that doesn't have all of the countries in Latin America. So in my hospital, when you have a protocol approved, you can go to look for these hours specifically dedicated to research. So this is a key part to start. And also, we also have some grants, not so much money, but it's very important to apply for this. For example, Juan Pablo started with a grant in my hospital. He won a grant, and that's the reason why we have these 3D printers. So also it's very important to apply for these grants that will help to do this research that needs some kind of requirement. And well, that's it. The other thing that we have is that we had not a small, like I think that for Latin America, we have important support from the Department of Research. And right now we have like 5 or 6 reviewers. And also we had an editor for the New Journal. So we have support in this. And sometimes in my hospital, you can apply for the fee, to pay the fee. It's not easy. It's easy to go to open journals, but you can do everything if you do with a good work, you are dedicated with that. But yes, it's very important to have the time. So
yeah, and I guess that this is a good time as any other to a couple of plugins. We do have 2 programs in particular. We have a program with the World Federation of Pediatric Imaging to support research. So if you are looking for, again, like kind of guidance and mentorship, we can do it through WFPI. We also have a new program that I know that we are coming with our second batch of also research support here from the Children's Hospital of Philadelphia. We had the pleasure of having Claudia Lazarte from Peru and Andres Garcia from Uruguay, and now we're bringing Jose Lipsic from Argentina and Esteban also from the Garrahan. Again, like just kind of a proposal for partnership, so we can guide you through some projects that are of interest to us, but that we think that it will be better served done by our partners in Latin America. So we also have a couple of open positions in our team. So if you are interested in joining the Latin American diaspora in the US, please reach out. Again, we are gonna get started now with the case, but thank you very much, Carlos. Stay on so you can see the cases and vote. We relied on the judgment of all these people to decide who's going to be the winner.
That would be awesome.
All right, so we pass it on to Dr. Miranda.
Good morning, everyone. So now for the moment of truth, we will have our first case of the day. The first case is presented by Dr. Karina Videla. She's from the Sanatorio de Niños de Rosario in Argentina, and she's going to present a case of Lemierre syndrome.
Buenos días a todos, mi nombre es Karina Videla, soy residente de cuarto año en la Fundación Villavicencio de Diagnóstico por Imágenes de Rosario, Argentina. Les presento el caso de una paciente atendida por guardias en el Sanatorio de Niños de 12 años de edad, sexo femenino, cuyo motivo de consulta fue fiebre, dolor y tumoración en la región anterior del cuello. Como antecedente, tenía diagnóstico hace 15 días de faringoamigdalitis que se trató con amoxicilina en forma ambulatoria en otra institución. Al examen físico se constató mal estado general, palidez cutáneo mucosa, taquicardia, taquimnea, faringe congestiva y temperatura de 39 grados. Como antecedentes perinatológicos es una recién nacida prematura de bajo peso por hipertensión materna inducida por el embarazo. Durante la lactancia presentó episodios de bronquiolitis que requirieron internación. Las pruebas de laboratorio evidenciaron anemia, leucocitosis, plaquetopenia, aumento de los reactantes de fase aguda, tiempo de protrombina prolongados e hiponatremia. Se solicitó radiografía de tórax y ecografía de partes blandas de cuello. La radiografía anteroposterior de tórax muestra una acentuación de la trama peribroncovascular a predominio pulmonar derecho. En región anterior del cuello se evidencia una colección hipoecogénica de contornos irregulares en situación anterior a la glándula tiroides subjetiva de colección. El Doppler evidenció un defecto de relleno en la vena yugular interna derecha. Se interna en unidad de terapia intensiva por sospecha clínica de shock séptico secundario absceso periamigdalino complicado. Se solicita tomografía de cuello y tórax con contraste para evaluar extensión de colección a espacios retrofaringeos y al mediastino anterior con los siguientes hallazgos imagenológicos. En proyección anterior a la glándula tiroides se visualizó una imagen heterogénea con presencia de burbujas aéreas, refuerzo de la pared tras la inyección de sustancia de contraste sugestiva de colección, defecto de relleno a nivel de la vena yugular interna derecha. Los cortes axiales en ventana pulmonar mostraron múltiples formaciones nodulares de contornos irregulares en ambos campos pulmonares, la del lóbulo inferior izquierdo de aspecto cavitado con comunicación bronquial. Dichas imágenes se interpretan como abscesos pulmonares. La angiografía mostró defectos de relleno a nivel de ambas arterias lobares inferiores compatibles con tromboembolismo pulmonar. El ecocardiograma Doppler, los hemocultivos y el hisopado nasal para Staphylococcus aureus resultaron negativos. Ante el contexto clínico de la paciente y los hallazgos por imágenes, se realizó el diagnóstico de síndrome de Lemierre con septicemia y abscesos pulmonares. Se indicó tratamiento antibiótico de amplio espectro que incluyó piperacilina, tazobactam, vancomicina y clindamicina. Se realizó punción percutánea bajo guía ecográfica de la colección con toma de muestra que incluyó escaso material y se rescató Staphylococcus epidermidis que se interpretó como muestra contaminada. A las 48 horas la paciente presenta mala evolución con trastorno de la perfusión, oliguria, dificultad respiratoria, tos con esputos hemoptoicos, hematemesis que generaron inestabilidad hemodinámica y depresión del sensorio. Se solicitó angiotomografía de tórax con los siguientes hallazgos. En el lóbulo inferior izquierdo se visualizaron vasos dilatados y abirraigados rodeados de un área hipodensa con menor vascularización, compatibles con dilatación pseudoneurismática de la rama segmentaria arterial pulmonar posterobasal izquierda. La resonancia de cráneo con gadolinio mostró una alteración de señal córtico-subcortical occipital paramediana izquierda, hiperintensa en FLAIR con restricción en secuencia de difusión sin realce al gadolinio. Debido al contexto clínico, se planteó la hipótesis de lesión inflamatoria en estadio temprano con resolución posterior en estudios de control. Se interconsultó al Departamento de Neumonología y Hemodinamia, quienes planificaron la embolización. La paciente evolucionó con buen estado general, afebril, hemodinámicamente estable, por lo que se decidió su externación y control por consultorio externo. El síndrome de Lemierre es una patología poco frecuente y potencialmente letal. Se origina como complicación a una infección orofaringea aparentemente resuelta y se manifiesta como un cuadro séptico caracterizado por fiebre y odinofagia de varios días de evolución. Es causada por un microorganismo anaerobio. El Fusobacterium está presente en el 81% de los casos de los pacientes con síndrome de Lemierre. Afecta típicamente a pacientes inmunocompetentes entre los 16 y los 25 años. El pseudoaneurisma de la arteria pulmonar es una complicación infrecuente y potencialmente mortal del absceso pulmonar y se puede controlar mediante la embolización de la arteria pulmonar o la resección quirúrgica. Muchas gracias por su atención.
Okay, now we have Dr. Francisca Aliaga from La Clínica Alemana de Santiago in Chile, and she's gonna present left ventricular apical hypoplasia.
Greetings, everyone. My name is Francisca Aliaga. Greetings, everyone. My name is Francisca Aliaga. I'm a radiology resident from Clínica Alemana de Santiago, Chile, and I'm very pleased to present you a clinical case of left ventricular apical hypoplasia. This is a case of a 28-year-old male patient who lives in a city far from highly complex centers, with a long-standing history that began on the first day of life, in which he presented respiratory failure and septic shock, being diagnosed with jejunal atresia, for which he underwent surgical repair. During his childhood, he presented with frequent anemia and epistaxis, requiring blood transfusions. In that same stage of life, he presented exertional dyspnea and syncope, underwent a series of tests, and was diagnosed with dilated cardiomyopathy at age of 7. At age 17, treatment with beta blocker was started, remaining stable for several years. At age 24, an electrophysiological study was performed, which was negative for induced arrhythmias, but a first-degree atrioventricular block was diagnosed. At age 27, he presented respiratory distress for 2 days, which was associated with atrial flutter that was cardioverted, requiring treatment with amiodarone, rivaroxaban, furosemide, and spironolactone. After hospitalization, a cardiac MRI was performed, and it shows typical findings of isolated apical hypoplasia of left ventricle. The patient was remaining stable with medical treatment. This is the electrocardiogram that was performed, where we can see first-degree atrioventricular block and left atrial enlargement, as well as other findings, such as right axis deviation, borderline QTC, poor precordial airway progression, very deep S waves, and non-specific ST waves changes. In this case, the timely diagnosis was important because it can determine the cause of the symptoms, and on the other hand, carry out genetic counseling because the disorder can be hereditary. Despite this, the treatment does not change much because it's medical. About the images, first we perform a cardiac MRI. This is the 4-chamber view in Fiesta that shows the enlargement of the right ventricle, we can see here, with the intraventricular septum displaced toward right ventricle. And also we can see papillary muscle displaced toward the left ventricle apex and a spherical truncated left ventricle, where we can see here, and non-compacted fat infiltration of the left apex. So this gives the banana shape of the right ventricle. We can see here. You can imagine a banana here. Then we perform a CT that shows the same findings as MRI. This is a coronal reconstruction, and we can see a truncated left ventricle with hypoplasia of that ventricle. And also, we can see fatty infiltration in the short axis view. We can see here. So this is 4 unique morphologic findings that can be isolated or associated with other congenital anomalies. So it has a variable clinical presentation, and a multimodality imaging is needed for the diagnosis. These are my references. Thank you so much.
Now for our next case, we're going to have Dr. Rodolfo Lorenzo from Brazil. He's from the Children's Institute Clinical Hospital, University of Sao Paulo. He will present a case of recurrent respiratory papillomatosis.
Hello, my name is Rodolfo Lourenço, and I'll be presenting a case of recurrent respiratory papillomatosis from Instituto da Criança do Hospital das Clínicas in São Paulo, Brazil. Our patient is a 14-year-old female born in 2008 at 38 weeks uneventfully. By the age of 2, she started presenting recurrent respiratory infections until she had stridor and respiratory failure at 7 years old, underwent orotracheal intubation, and polypoid lesions were seen in vocal cords, larynx, and trachea. Upon further investigation, it was discovered that the mother had poor prenatal care and had genital warts at the time of vaginal delivery. The diagnostic hypothesis based on the clinical and obstetric history was recurrent respiratory papillomatosis, which was confirmed later by biopsy of the tracheal lesions. A chest CT was performed a few months after, when the symptoms got worse and the patient needed tracheostomy and regular resection of the papillomas. But a year later, the patient had intermittent clinical follow-up with erratically resections of the papillomas. So this is the first exam, when the lesions were first discovered and the pulmonary parenchyma doesn't show any evidence of involvement. Less than 1 year later, however, after symptoms got worse and the tracheostomy was performed, there can be seen some sparse nodules on the X-ray, and the CT showed multiple nodules, some of them excavated with a diffuse distribution. This is a 3D image of those nodules showing the lungs involvement. In 2020, after appropriate follow-up again, the lesions were even more evident, with bigger papillomas that are until this day resected every 15 to 30 days. The solid and excavated nodules also became bigger, and some of them confluent, and the airway polypoid lesions kept appearing, as showed by the red arrow. This is the patient's most recent CT from the end of last year, and the lesions almost completely occupy the lower lobes. New polypoid lesions kept growing in the airways, as those showed by the red arrows again. And lung infections are ever more frequent, with the need of upscaling to high-end antibiotics. So this is the development of the disease throughout the years, seen on X-ray and CT, showing not only the development of new papillomas, but also the growth of the nodules to become masses mainly seen in the lower lobes. Recurrent respiratory papillomatosis has a poor prognosis, and there is no definitive treatment. We rely on palliative measures with recurrent surgical excisions, tracheostomies when necessary, multiple biopsies due to a small risk of malignant transformation to squamous cell carcinomas, and in some cases, adjuvant therapy to slow regrowth of the papillomas. The incidence in children is approximately 4 in 100,000, but is higher in places with low socioeconomic status for reasons as higher HPV infection prevalence, low educational levels, and less access to prenatal care. So our take-home points are: HPV acquired in childhood during vaginal delivery from mothers with genital lesions is the reason this disease exists. The larynx is usually the only organ that is affected. Central airway involvement occurs in less than 5% of the cases, and involvement of the pulmonary parenchyma in only less than 1% of the cases. The appearance on CT are nodular lesions in the larynx and trachea, and solid or cavitated nodules in the lung parenchyma. The best options to fight the disease is inadequate prenatal care and HPV vaccination, which unfortunately aren't still easily available everywhere. Those are the references we used. Thank you very much.
Okay, now we have Dr. Jennifer Richardson from the Instituto Roosevelt in Colombia, and she's going to present a typical hepatic mesenchymal hamartoma.
My name is Jennifer Richardson, radiologist at the Roosevelt Institute in Bogotá, Colombia. Today I'm going to present a case of a typical mesenchymal hamartoma organized by Javier Pacheco, our mentor Dr. Marta Oyuela, and other team members Dr. Jose Valle. Newborn at term 37 weeks gestation cesarean delivery due to abdominal cystic mass on prenatal ultrasound. Birth August 2022 and weight 2,925 grams. First baby from 25-year-old mother with adequate prenatal control, normal laboratories during pregnancy without perinatal infections, low socioeconomic conditions, no significant family or personal medical history. An ultrasound of the abdomen revealed a large anechoic cystic mass occupying abdomen. On physical examination, a globus abdomen in good general condition without respiratory distress or cough, tolerates orally adequate suction. There was no hepatomegaly or splenomegaly. The liver function test and gamma-glutamyl transpeptidase were normal. All hematological and other biochemical tests were also normal, except by elevated serum alpha-fetoprotein. He wasn't febrile or icteric. The CT scan of the abdomen showed a large retroperitoneal cyst mass with a large diameter of 11 centimeters located in the anterior pararenal space with anterior displacement of the intestine. There was no calcification, nor was there any soft tissue component with it. According to the clinical history reports of abdominal ultrasound and echocardiogram were obtained, where a cystic abdominal lesion was found that occupies the entire abdomen without a solid component, with echocardiogram described as a normal. This study is carried out extra-institutionally in a rural population from when they refer to our institution. Abdominal MRI reveals a cystic retroperitoneal mass with thin septa hyperintense on T1 without enhancement of septa or solid component inside obstruction. In this axial section, in sequence enhanced in T2 hyperintense lesion is observed in space for anterior renal, with a slight displacement of renal structure backwards and intestinal lobes forward, more evident the thin septum without solid component. There were multiple internal septations within, however, no solid component was visible. It extends from the infrahepatic and infrasplenic spaces to the pelvic cavity. In sequence T1 with contrast, it is appreciated that there is no solid component or enhancement of the septum inside. With all this information, where does the tumor originate from? Retroperitoneum, kidney, liver, adrenal glands? What is your most likely diagnosis? Giant mesenteric cyst, ascites, low flow vascular malformation, lymphatic, or none of the above? Is it a vascular anomaly? In this table, we are shown the latest classification of vascular anomalies published on 2020. In this context, it will correspond to a simple lymphatic vascular malformation as the main differential diagnosis. These cases obtained from Radiopedia show other possible etiologies, including mesenteric cyst lymphangioma and mesenteric cyst, which are observed hypodense in abdominal tomography, occupying a large part of the volume of the abdominal cavity at the retroperitoneal and peritoneal level without solid component. A multidisciplinary meeting is held on September 2, 2022 to define behavior. It was decided to perform function of the lesion guided by ultrasound with complementary laboratory tests that rule out the origin of the thoracic duct, Analyzing its appearance with triglyceride measurement, the results yield a yellow liquid without alteration in the values of triglycerides, cytochemic, or culture, as shown in the next slide. Resection of the lesion is decided in a multidisciplinary manner. Surgical resection was performed by pediatric surgery, finding a large intraperitoneal cyst with a smooth surface, serous content occupying 60% of the abdominal cavity without adhesions to intestinal lobes or retroperitoneum, originating from the posterior face free edge of segment 5 of the liver. Taking into account the origin of the cystic lesion, what is the definitive diagnosis? Congenital simple liver cyst, mesenteric cystic lymphangioma, hamartoma mesenchymal hepatic, hydatidec cyst, hepatoblastoma, undifferentiated embryonal sarcoma or infantile hemangioendothelioma. Histopathologic result reports hepatic mesenchymal hamartoma. In the pathology report, it was labeled as a liver cyst. Microscopic description or cyst surrounded by loose connective tissue is initiated with atypia or malignancy as shown in the image. The most common liver implants in children is metastasis. Primary liver malignancies in pediatrics account for only 0.5% to 2%. Of the liver neoplastic in children, approximately 70% are malignant and 30% are benign. Of the malignant plants, hemangioendothelioma is the most frequent. Hepatic mesenchymal hamartoma represents 80% of liver tumors in children. 80% occur in the first 2 years of life. Rare cases have been reported in adults. It's most prevalent in male and right lobe of the liver. There is no racial prediction, and the term hepatic mesenchymal hamartoma was described by Edmondson in the 56 and defines it as cystic mesenchymal lesion composed mainly of connective tissue containing a lot of serous fluid. However, depending on the amount and nature of the tumor, it may present as cystic or solid mass. Hepatic mesenchymal hamartoma was traditionally considered a rare development benign liver condition in children, but recent reports of specific translocations affecting chromosome 19, certain histologic features, and the finding of a neoplasty in mesenchymal hamartoma suggest that the mesenchymal hamartoma may be a true neoplasm rather than a development anomaly. The typical presentation is asymptomatic, rapid abdominal distension with a palpable mass on physical examination. The rapid expansion of the tumor is shown to be due to mesenchymal degeneration and fluid accumulation. Other common associated symptoms are vomiting, fever, constipation, diarrhea, and weight loss. Alpha-fetoprotein may be elevated. Alpha-fetoprotein levels are higher in patients with solid hepatic mesenchymal hamartoma. Internal complications include polydramnios, hydrophthalmia, respiratory distress, and ascites. The imaging spectrum of hepatic mesenchymal hamartoma parallels macroscopic pathologic appearances. The first one is the echography, that shows cystic areas have thin or thick echogenic septa and detritus. Solid portions appear echogenic. Color Doppler flow images show minimal vascularization in solid areas and septums. The other one that we have is the tomography that shows hepatic mesenchymal hamartoma appears as a complex cystic mass. The contents of the cystic are water, isodense, and the stromal elements are hypodense to the liver. And the last one is the MRI that shows the appearance depends of the relative predominance of cystic versus stromal elements and the protein contents of the cyst. Cystic areas are markedly hyperintense in T2 weighted image and have variable signal strength in T1 weighted images. Solid areas appear hypointense on T1 and T2 weighted images due to fibrosis. However, interspersed areas and hyperintense have been observed in T2 enhanced images. Isolated contrast enhancement of stromal components and septums is observed on both CT and MRI, however, no capsule is seen. In this article, published in 2007, the Sons he et al. Included in their study 13 children with a pathological confirmed hepatic mesenchymal hamartoma. The male to female ratio was 7 versus 6, with a mean age of 3 years and 2 months. The conclusion of this study is that hepatic mesenchymal hamartoma in children can show a wide spectrum of radiological features from a multiseptated cystic tumor to a mixed solid and cystic tumor, and even a solid tumor. We have 3 examples of this presentation. The first one is that the mass have a cystic component of a huge have septas that is tenet and not have enhancement of the CT. The second case shows a mass that have a solid and cystic component. And the third one is that only have a solid component without a cystic. There are many diagnosis considerations for a liver mass in a child as seen in the table. Hepatoblastoma is characterized by very high serum alpha-fetoprotein, solid aberrance, and calcification. Epithelate hemangioma with stromal mixed change can be distinguished by enlarged vessels, peripheral nodular enhancement with centripetal filling and calcifications. Undifferentiated embryonal sarcoma occurs in older children between 6 and 10 years of age and is distinguished by a frankly malignant stroma and frequent hemorrhage and necrosis. Surgical resection has been the standard treatment for this tumor. The first surgical options available are marsupialization of cyst, hamartoma excision, and hepatic lobectomy. The chosen procedure must be individualized. Thank you very much.
Okay, now we're ready for our 5th case of the day. This is presented by Dr. Fernanda Avalos from Hospital Metropolitano in Ecuador. She's going to present adrenal adenocarcinoma in a 5-year-old.
Good morning. My name is Fernanda Avalos. I'm from Ecuador. I have no disclosures, and my case is entitled Adrenal Adenocarcinoma in a 5-year-old girl living in an indigenous community in Ecuador. So our patient lives in Imbabura. Imbabura is a province that we have in the small map with red. Quito is the small blue dot. So mobilized between these 2 cities is more or less 3 hours by car. We don't have, a mother doesn't refer any routine postnatal checkups, so we don't have information about anthropometric data, immunizations, vitamins, or metabolic screening. There is no medical past history of her. At the age of 3, she refers the appearance of facial and pubic hair and also acne that was managed with unspecific medication by a private doctor. At the age of 5, she fell from her bicycle and had an impact on the abdomen, after what she referred intense abdominal pain and headache. She was taken to the clinic of her town, and the doctor identified these high blood pressure values. After she started with seizures and her Glasgow scale was getting lower, with 11 she was referred to the city of Quito. 4 hours after that, more or less, she arrived to the 3rd level hospital in the capital. Her Glasgow was even worse with 6 points, so she was admitted to the pediatric intensive care unit. The physical exam we are gonna see in the next slide, and they also performed blood tests. The blood tests show elevated cortisol, testosterone, and liver enzymes. The rest of the laboratories were within normal. Here at the physical exam, first I want you to notice that she seems like bigger girl than 5 years old. She has pubic hair, acne, and facial hyperpigmentation, so this can guide us what kind of hormone is getting higher in her body. With this, and they pulp like a mass in the left lung, they continue with an ultrasound, and they confirm a big mass at the left lung. Suppose or impressed that it was dependent of the adrenal gland, so we continue with a CT scan. Here we have the enhanced CT scan. There is a huge abdominal mass that is dependent of the left adrenal gland. It has an heterogeneous enhancement, irregular shape, and as you can see, the left kidney is not visualized here because it is displaced. Also on the non-enhanced CT scan, we saw a lot of calcifications. And another finding here was that in the lower slides of the lung, we saw lung nodules. So we continue with a chest X-ray and we confirm multiple lung nodules. So with her symptoms, with lab tests and the imaging findings, we conclude that we were in front of adrenal adenocarcinoma with pulmonary metastasis. So she was not eligible to surgical management as she was a 4th grade, but her family insisted and she underwent to surgery. Sadly, she didn't survive and died 24 hours after that because she had a hypertensive crisis. So here my take-home points is that we are in front of an adrenal mass in a young girl with virilization. We can see here the virtual reality reconstruction, and we can see a very huge mass. It was a heterogeneous enhancement, had calcifications, the shape was irregular, displaced the left kidney. So these kind of tumors are very rare. It's more or less reported 0.6 to 2 per million. It has 2 peaks, and she was in one of those peaks. I want to emphasize the determinants of health in her that reduce the possibility of an early diagnosis. Sometimes for indigenous community can be difficult to find a specialized healthcare or clinics, so they have less access to health service and their socioeconomic sometimes is even more difficult. This also, with the level of education of the family, make that the diagnosis was really late and we cannot offer any prognosis to her. I want to say thank you to everyone, to Dr. Lucia Gomez. Here are the reference. I hope you enjoy this case.
Okay, now we have Dr. Maria Andrea Busi from Ricardo Gutierrez Children's Hospital from Argentina. And she's going to present glial heterotopia in a newborn.
Hello, my name is Andrea Busi. I'm a first-year resident in pediatric radiology at Ricardo Gutierrez Children's Hospital in Buenos Aires, Argentina. First of all, I would like to thank you for this opportunity. I'll share with you a case report about intra- and extranasal glial heterotopia in a newborn with congenital nasal tumor. Before I start, we do not have any disclosure. The clinical case is about a full-term female newborn with appropriate weight for gestational age, product of a partially controlled pregnancy and vaginal delivery without complications, and no family history of disease. She was referred from a peripheral health center at birth, being 4 hours of life because of the presence of a nasal tumor not detected in prenatal studies. During the physical exam, she showed a tumor at the left side of the nasal bridge, which was observed since birth, measuring 3 by 3 centimeters, rubbery, mobile, of purplish coloration and pains. She did not show any feeding difficulties or any upper airway involvement. With these features, the first suspected diagnoses were vascular malformation versus encephalocele. Initially, soft tissue ultrasound was requested, showing an ovoid image with defined limits, relatively homogeneous ultrastructure, and solid appearance, with low vascular density at the Doppler exam, ruling out the congenital hemangioma diagnostic. So, in order to deepen the study, a cranial MRI without contrast was conducted. We have a T1, T2, and FLAIR-weighted images and a short video showing a solid formation with a small intranasal component in the left nasal fossa over the nasal root, with similar signal to the encephalic parenchyma in all the sequences. And in this image, there is a 3D reconstruction T2 weighted MRI, where it's shown that the mass has no relation to the endocranial or encephalic content. In order to assess the bone structure, a CT of the craniofacial mass was performed, showing a wine bone defect of the nasal bridge and expansion of the roof of the left nasal fossa in relation to the known tumor. Now, in this picture, we can see the correlation between the 3D reconstruction in the left, where a bone defect is seen in relation to frontonasal mass. That is shown as a blur area marked with a white arrow, and the nasal mass in the right. Surgery with complete excision and reconstruction of the nasal dorsum with skin flaps was performed, and a sample was submitted for pathological anatomy. The final report showed glial tissue in the dermis that sits on a fibrillary matrix and coexists with tracts of vascularized fibroconnective tissue. Findings that are compatible with glial heterotopia, also known as frustrated encephalocele. So let's talk about glial heterotopia. The incidence of congenital midline nasal masses are 1 per 20,000 live births. The most common are dermoepidermoid tumors, nasal cerebral heterotopias, nasal encephaloceles, and less probably vascular tumors. Nasal glial heterotopia account for approximately 5% of all the congenital nasal swellings. They are benign congenital tumors due to an ectopic trapping of herniated brain and glial tissue. There are 3 types of them. 60% are extranasal, located external to the bones and nasal cavities. 30% are intranasal, and 10% are the mixed type, which includes our patient. Although in general asymptomatic, the clinical manifestation may include nasal obstructions, epistaxis, hypertelorism, and cosmetic deformity, among others. The diagnosis is confirmed with pathological anatomy. Histological confirmation of total tumor removal is important because recurrency in case of microscopic residue is up to 10%. We conclude that our take-home points must be to know that nasal glial heterotopia are rare congenital anomalies that are usually asymptomatic. It is mandatory to rule out intracranial extension by cross-sectional imaging. CT and MRI differentiate nasal heterotopia from other congenital nasal masses. CT can show bone defects, and MRI the characteristic of soft tissue mass and its possible intracranial connection. Even though these lesions are benign, early surgical intervention is recommended to avoid further significant local damage or cosmetic deformity. If they're not surgically removed, it can cause bony atrophy and intracranial communication, which may predispose to meningitis and other infections. These are our references. Thank you very much. Muchas gracias.
These are all great cases. We're ready for our 7th case of the day, presented by Dr. Jorge Luis Guayanay Espinosa from Peru. He comes from the Instituto Nacional de Enfermedades Neoplásticas, and he's going to present orbital metastasis from breast carcinoma.
Hello, everybody. My name is Jorge Luis Guayanay Espinosa. I'm a radiologist from Instituto Nacional de Enfermedades Neoplásticas in Lima, Peru. I work with Fanny Angelo Arte Castillo. She's a 3rd-year radiology resident from our institution. Our mentor is Dr. Mark Gelfbach from Jacobi Medical Center in New York, USA. We do not have any funding declaration or conflict of interest to declare. Our patient is a 57-year-old female with history of triple-negative left breast invasive lobular carcinoma. She was treated with neoadjuvant chemotherapy and subsequent mastectomy. She developed osseous metastasis 2 years after surgery, for which she received capecitabine for 4 months. Post-therapy, she presented with visual changes, but was able to present for a follow-up appointment 2 months after the onset of symptoms. At the time of the follow-up visit at our institution, she already presented with left enophthalmos. A HCT and MRI were performed, showing orbitary muscle enhancement. An incisional biopsy was performed, confirming orbitary metastatic involvement from primary breast lobular carcinoma. Breast imaging findings at the time of diagnosis include left breast MLO and CC mammograms, revealing a dense, irregular breast mass with spiculated margins indicated by the yellow arrows. Breast ultrasound image shows an irregular hypoechoic mass that corresponds to mammographic finding. Posterior acoustic shadowing is also noted, indicated by the yellow star. Contrast enhanced HCT in axial and coronal views show orbitary muscle thickening and enhancement indicated by the blue arrows. A FLAIR image shows asymmetric enlargement of the left extraocular muscles. with associated intraconal fat infiltration indicated by the red arrows. ADC weighted image shows restriction to diffusion indicated by the green arrows. T1 fat saturated contrast enhanced axial, sagittal, and coronal images show enhancement of the extraocular muscles of the left orbit with associated infiltrative enhancement of the intraconal fat and surrounding soft tissues extending to the perceptual region indicated by the orange arrows. The orbit contents and the optic nerve are not affected. The patient received radiation therapy in the orbitary region with no significant change in size of the metastatic orbitary lesion. 2 months later, leptomeningeal metastatic involvement was reported, for which allocranial radiotherapy and intrathecal chemotherapy were utilized. Subsequently, the patient developed cognitive impairment and oral intolerance. Gastroscopy showed ulcerated lesions in the gastric wall. Biopsy of these lesions showed metastatic involvement from mammary carcinoma. The patient is still under chemotherapy with carboplatin and paclitaxel and developed pancytopenia. Due to recent sociopolitical instability in our country, the patient is not able to obtain regularly scheduled follow-up MRIs at our hospital. These T1 fat saturated contrast enhanced axial and coronal images show left gyriform parieto-occipital leptomeningeal enhancement concerning for metastasis, indicated by the purple arrows. Invasive lobular carcinoma constitutes about 14% of all breast malignancies and presents different morphology and histology when compared to the more common invasive ductal carcinoma. Due to its pattern of growth, ILC is more likely to infiltrate peritoneum, ovaries, leptomeninges, myocardium, orbits, and gastrointestinal tract. Relative estrogen abundance within these tissues is also a key factor. Orbital metastases are rare and are often found in the context of widespread disease. Up to 70% of the cases are discovered in patients with primary breast carcinoma. Lobular carcinoma is the most common histological subtype involved. Our institution is a state hospital based in Lima and is the primary cancer center in Peru. On a daily basis, we treat oncologic patients from the entire country, including provinces outside Lima. Since the end of 2022, there has been political unrest in Peru. Protesters have blocked roads, taken over airports, and set some buildings on fire, demanding the president's resignation, Congress closure, and a new constitution. Since the patient was living in another city and could not afford commuting expenses to the hospital on a regular basis, she frequently experienced delays with the follow-up visits. Delays in her care were further aggravated by the local civil unrest and unsafe traveling conditions. While every Peruvian is affected by these events, underserved populations are the most affected. All of these lead to unchecked progression of disease. Attempts to decentralize oncologic healthcare have been started in our country with new regional oncologic centers based in Lima and in Arequipa, Trujillo, and Concepcion. These new centers are run by physicians trained in our institution. It is our hope that patients will not need to travel long distances to obtain adequate oncologic care.
Okay, now we have Dr. Diego Basáez Núñez from Hospital Clínico Universidad Católica, Pontificia Universidad Católica de Chile, from Chile, and he's going to present extralobar pulmonary sequestration.
Okay. So then let's get to good case.
Hello, my name is Dr. Diego Basáez. I'm a second-year radiology resident at Pontificia Universidad Católica de Chile, and I'm going to present to you our case, extralobar pulmonary sequestration, presenting as a drug abdominal mass with diaphragmatic interruption in a full-term newborn. So our case starts with a 32-year-old pregnant woman with no previous medical history that was referred to our tertiary medical center because of a posterior mediastinal mass that was found in a routine 18 weeks fetal ultrasound. A fetal magnetic resonance was performed. Here we can see some selected images of the fetal MRI. These are sagittal and coronal T2 weighted, and we can identify this large posterior thoracoabdominal mass that extends to the left upper quadrant of the abdomen through a large diaphragmatic defect that is about 3.2 centimeters long in its major axis. This mass is right next posterior to the heart, has well-defined margin, and is hyperintense in T2 with some fine hyperintense septi. With these imaging features, pulmonary sequestration was suggested as a possible diagnosis. The pregnancy was then interrupted at 38 weeks of gestational age via C-section with no major incidents. A 3.2 kilogram male was born, And at the first day of life, an ultrasound was performed, and we can see here in a transverse oblique plane a large posterior well-defined hybricoic mass with an arterial blood vessel arising from the aorta. At the second day of life, a computed tomography was performed. Here we can see again there is a large thoracoabdominal hypodense mass that has some enhancements with the administration of IV contrast. And in this sagittal plane of the angiographic phase, we can see a feeding artery arising from the aorta about 4 millimeters proximal to the region of the celiac trunk. And in this coronal reconstruction of the venous phase, we can see a blood vessel draining to the left renal vein. So this surgery was performed on the second day of life. The mass was completely resected and the diaphragmatic defect was repaired with no major incidents. A few weeks later, pathology confirmed the diagnosis of an extralobar pulmonary sequestration with some cystic dilated spaces, and it was covered in mature ciliated epithelium with no signs of malignancy. The patient was discharged at 18 days of life, and he was returned to his hospital of origin. So pulmonary sequestration is a rare congenital abnormality. It stands for about 6% of all pulmonary congenital abnormalities. They can be intralobar or extralobar depending on the visceral pleura, if it is shared with the normal lung tissue or if it's independent. And they have a systemic arterial supply. Usually it comes from the aorta, or it can come from the other systemic arteries such as the celiac trunk, and the venous drainage can vary. It can go to the pulmonary veins, azygos, hemiazygos, or even the portal system. Pulmonary sequestrations can be associated with other congenital anomalies such as congenital heart diseases, congenital pulmonary airway malformations, and congenital diaphragmatic hernia. In these cases, the hernias tend to be posterior and left. So this case with an hiatal defect is actually pretty rare, and its thoracoabdominal location makes it even less common. So there are some imaging features, and we can use MRI, ultrasound, and CT to differentiate it from other differential diagnoses such as posterior mediastinal masses or adrenal masses that can be malignant. So thank you, and this is my presentation.
We have 2 more cases before a brief intermission. So next we have Dr. Daniel Quintero Pulgarin from Fundación OMI, Universidad Nacional de Colombia in Colombia. He will present a case on Ascaris lumbricoides in the biliary tree.
Hello to everyone. My name is Daniel Quintero Pulgarin. I am a pediatric virology fellow at Universidad Nacional de Colombia and Fundación OMI, a pediatric hospital in Bogotá. My mentor is Dr. Luz Ángela Moreno Gomez, a pediatric radiologist. We present an Ascaris lumbricoides in the biliary tree in a 2-year-old girl from Puerto Meluc, Medio Baudó, Chocó, Colombia. Our patient was taken to a hospital in Quibdó, Chocó by her mother with 4 days of liquid stools without macroscopic blood, multiple emetic episodes, continuous diffuse abdominal pain, and fever. As for her medical history, she had complete vaccinations and a negative perinatal and surgical history. She lived in Puerto Meluc, which is a small town within a municipality in Chocó, Colombia called Medio Baudó. It is near the Pacific coast in the department of Chocó, and it has some issues that are determinant for the incidence of ascaridiasis in its population. It is far from Quibdó, the capital of the department of Chocó. It has a tropical rainforest climate, It has no paved roads, no universal access to water nor sanitation, and for us, as for our patient, she shared a single household with her mother, grandmother, and several aunts and uncles, with no access to drinking water and frequent contact with farm animals like pigs and poultry. At admission at Kivdo, she was stable with mild dehydration, leukocytosis with neutrophilia and eosinophilia, and microcytic hypochromic anemia. Tests for malaria and coproscopic for parasites were negative, and as she persisted with abdominal pain, fever, and diarrhea, she was given empirical wide-spectrum antibiotics and antiparasitics. After this treatment, multiple microscopic nematodes were visualized in her feces and also were spontaneously shed out from her anus. She was suspected to have disseminated ascariasis, and she was transferred to a hospital in Bogota for further evaluation, where tests for primary immunodeficiencies and HIV were negative, but closely after admission, liver transaminases and direct and total bilirubin began to elevate progressively. So with this cholestatic pattern, she was taken to an MR cholangiography that, as a first finding, at this actual fat saturated T2, it was demonstrated the presence of at least 2 T2 hyperintense spheric lesions in the liver parenchyma consistent with abscesses, and also at this coronal and sagittal T2 images, a diffuse dilation of the intrahepatic biliary tree and of the common bile duct was seen, with special attention to this lineal T2 hypointense image within the dilated common bile duct that was also confirmed in the specific cholangiography sequences, and at this clinical context, it was reported as an ascaris in the common bile duct, producing the cholestatic and obstruction. Our pediatric hepatobiliary surgeons performed an endoscopic retrograde cholangiopancreatography that confirmed the dilation of the biliary tree and the presence of an ascaris lumbricoides in the dilated common bile duct, seen here as a lineal filling defect. With a balloon-assisted technique, you can see here the balloon represented in green. The ascaris was pulled out of the common bile duct, and then it was liberated into the duodenum. At the next day, the mom reported that the patient had an emetic episode where the ascaris was eliminated, and she was discharged with improvement of the cholestatic pattern and the inflammatory markers, and with recommendations of treatment of all the family members with antiparasitic drugs. Some take-home points: biliary ascaridiasis is considered rare. Most cases are reported in tropical areas with high-risk hygiene behaviors and inadequate sanitation. MR cholangiography is a very useful modality, especially for the complications, but ultrasound should be the first modality employed, although it's frequent that the diagnosis is missed, and multidisciplinary approach is necessary for the management. These are some references, and thank you for your attention.
Okay, now before the brief intermission, we have Dr. Carlos Almeida Cedeño from Hospital Metropolitano in Ecuador. He's going to present acute thoracic pain in a young woman.
Hello everyone, my name is Carlos Almeida. I'm a second-year radiology resident from Quito, Ecuador. I work at Hospital Metropolitano. Today I'm going to present this case that is titled Acute Thoracic Pain in a Young Woman. It is not always the heart. So some clinical findings and clinical history about this patient. She was an 18-year-old woman who was a first-year medical student. She came to the ER with a sudden left chest pain that began 3 hours before the admission. She described the pain as very intense. It interrupted her sleep and did not present any accompanying symptoms. As a clinical background, she said that she presented recurrent epistaxis since childhood, and the last episode was 2 years ago. And she also had an atypical pneumonia 6 months before, without need for hospital management. It's important to say that in the clinical examination, she presented with some telangiectasis in her oral mucosa. So some exams were ordered in the ER and chest X-ray was performed. So we can see that there's a left basal ill-defined opacity that it's located in the back of the heart, and also an obliteration of the left posterior costophrenic angle that was related with a pleural effusion. With these findings and the clinical findings, pulmonary thromboembolism with pulmonary infarction was suspected. So we decided to perform a chest CT angiography. And here are the images. And this pulmonary window, we can see a rounded formation that is located in the lower left lobe. It length 2.5 centimeters. And also some pleural effusion that was adjacent to it. So this finding in the contrast series was seen as a intravascular one. It had an arterial branch that was fitting it and also a venous drain. And it was categorized as an arteriovenous fistula or arteriovenous malformation. And also the pleural effusion had high density. It was cataloged as an hemothorax. So some 3D reconstructions were performed, and we can see that this pulmonary arteriovenous malformation of fistula, it has an arterial supply that is in red, and also a venous drain that was to the left inferior pulmonary vein. With these findings, a specific pathology was suspected, so we decided to perform some extension studies, and also a brain CT angiography was performed that didn't present any critical findings, and also an abdominal angiography was performed, and at the liver there were seen multiple confluent vascular areas that had the impression to be masses, but in the clinical context there correspond to telangiectasias in the liver. So we decided, we had the diagnosis with these findings, and some of the course of the disease. The patient underwent a surgery, a thoracoscopy 2 days after the admission, where an pneumothorax with clots was found, and also a saccular vascular malformation on the lower edge of the left posterior basal segment. So a lobectomy was performed too. The pathologic result said that this was an arteriovenous malformation that gave the appearance of an aneurysm or a venous lake. And the final diagnosis was an hereditary hemorrhagic telangiectasia or Randy-Olson-Weber syndrome because of the chronic epistaxis, the telangiectasias in the oral mucosa, and the arteriovenous malformations in the lung and in the liver. So the patient went to her home a week after the surgery. She still comes to have a clinical follow-up, and she's doing very well. Some key points to have in mind about this pathology is that the pulmonary arteriovenous malformations are often encountered in patients with suspected Randy-Olson-Weber syndrome, and it can be diagnosed either on genetic testing or some clinical criteria that are called Kurosawa clinical criteria. The patient had 3 out of 4 that makes the diagnosis, and the criteria are recurrent nose splits, telangiectasias and the skin and mucous membranes, visceral arteriovenous malformations, and the story of HHT in a first-degree relative. Well, this last one the patient didn't have. So this is it. These are some of the references that I use. Thank you very much for your attention. I hope you enjoy it.
Okay, we're ready to go back into the cases. I hope everyone back from the break. We will start with someone from Peru, Dr. Edgardo Dr. Ruby Quinto from Edgardo Rebagliati Martin National Hospital, who is going to present intermedullary neuroenteric cyst.
Hi everyone, I am Ruby Quinto, a radiology resident from Edgardo Rebagliati Hospital from Lima, Peru. Today, I'm going to present a case report named Intramedullary Neuroenteric Cyst and Atypical Location. We report a 1-year-old woman with no significant medical history and with adequate psychomotor development for her age. The history disease mentioned that she suffered a fall from a couch with a frontal trauma, without loss of consciousness, and immediately cried. Days later, she became irritable and developed a paraparesis that made it difficult to walk. Then she lost the control of her chest when she was sitting and had an inability to hold objects with her hands. On physical examination, doctors noticed a decreased muscle strain in 4 extremities, functioned in the Daniel score 3 of the 5 points. She also had hyperreflexia and hypertonia in the lower limbs, a bilateral clonus, and persistent pincer positions in both hands. With this physical examination, we could agree that this patient had an important neurologic damage. The laboratory tests, as you can see, they were all in normal ranges, which didn't contribute to the diagnosis. Doctors took first a brain and spine tomography. Here we have a sagittal section of the spine tomography, and what caught our attention is this widening of the medullary canal at the cervical level, here. Because of the history of trauma, it is important to mention that there is no evidence of vertebral fracture traces. Due to the rapid deterioration and progression of the symptoms, an MRI study of the cervical and dorsal spine was indicated. Here we have the sagittal section pondering on T1, and we can evidence an increase of cervical lordosis and a widening of the spinal cord at the level of C4 to C7 due to a well-defined cystic lesion that is hypointense in T1, as you can see here. And on this sagittal section pondered on T2, the lesion shows an hyperintense signal. In the axial section, we can see that this cystic lesion displaces and compresses the spinal cord forward, which produces an spinal cord compression syndrome. The patient underwent surgery. Here we have the surgery report, and mentioned that they made a linear incision from C2 to L1. They evidenced a protrusion and lack of heartbeat in the spinal cord and the presence of a cystic tumor that compresses and pushes the spinal cord forward on the right side. It was strongly adherent in the previous aspect. They performed a complete excision of the lesion and then noticed that the spinal cord recovered a heartbeat. The anatomopathological study defined this lesion as a neuroenteric cyst. Her postoperative evolution has been favorable, with a notable neurological improvement. Now she can walk with help and move her 4 extremities. She continues in physical therapy and neurologic controls. The take-home points are, first, that these neuroenteric cysts are rare congenital benign lesions that result from an incomplete resorption of the neuroenteric canal. It represents only 1% of all the primary tumors that affect the spinal cord. It could be classified to location in spinal or intracranial. The most frequent locations in almost 95% of all the cases is the extramedullary intradural location. The intramedullary location, as the case that we present, is really infrequent, with only 58 cases reported today. These neuroenteric cysts are usually associated with other congenital anomalies that affect the vertebral, respiratory, and digestive tracts. The treatment is basically the surgery and is variable, from a percutaneous aspiration puncture to a total resection of the cyst. It is also reported a high rate of recurrence. That's why the controls with MRI are recommended. This is the reference that I use. Thank you so much for your attention. Hi, everyone.
Now we're going to continue with Dr. Montserrat Cuadra from Hospital ABC in Mexico. She's going to present a 77-year-old man with sustained ventricular tachycardia.
Good morning. I am Dr. Montserrat Cuadra from Hospital ABC in Mexico City. My case is titled 77-year-old man with sustained ventricular tachycardia, and I do not have any conflict of interest. So as we stated before, this patient is a 77-year-old male, and his past medical history included non-Hodgkin lymphoma in remission for 10 years with only occasional follow-up. He was admitted to the ED due to palpitation, dyspnea, and fatigue, and ventricular tachycardia was diagnosed on site. So he was treated with the ACLS protocol, amiodarone, and synchronized cardioversion with output at sinus bradycardia. So the patient was admitted to the hospital for further investigation, and sustained ventricular tachycardia persisted. So a tricameral pacemaker plus an automatic external defibrillator were placed. A PET-CT was also ordered for follow-up on his previous history of NHL, in which cardiomegaly was confirmed. And later, a cardiac MR was also ordered for additional follow-up. So this is a coronal image from that PET-CT, and we can look at the electrodes of the cardiac pacemaker, defibrillator, with imaging artifacts and significant dilation of the cardiac silhouette or cardiomegaly is also identified. So in this PET-CT, we are also looking at an axial image at the level of the left ventricle with physiological metabolism of the ventricular myocardium. The pulmonary artery trunk also has an increased diameter, which is an indirect sign of pulmonary arterial hypertension, and pericardial effusion also coexists. So later, we got this other study, which is a cardiac MR. These two images are steady state free precession of 4-chamber view. We're looking at the left ventricular diastolic volume and another representation of the right ventricular end diastolic volume, which is low, and the arrows are pointing at pericardial effusion. These are images of the short axis SSFP. We can see a decreased biventricular ejection fraction, and in the right ventricle, the patient's ejection fraction is 38, and in the left ventricle, the patient's ejection fraction is 28. We can see that they are both very low compared to the normal measurements we see on the right. And thinning and asynchronia of the inferolateral basal and middle third myocardium was also observed. Here we are looking at late enhancement sequences. In the basal third, we observe septal intramyocardial enhancement, predominantly in the inferolateral region. These changes are transmural. In the middle third, we're seeing septal intramyocardial and inferior late enhancement. These are also transmural with anterolateral extension. And finally, in the apical third, we see lateral intramyocardial late enhancement. So the social determinants of health for the final diagnosis of this patient, which we're going to talk about later, is that during his adolescence and early adulthood, the patient lived in rural tropical areas in the east coast of Mexico and was dedicated to the cultivation of coffee and oranges. And housing in this area was substandard and primarily made up of palm and mud with no maintenance. So most of his life he lived in very low income communities with scarce access to healthcare and other resources. So trypanosoma cruzi test was reactive for this patient. So we're going to look at the conclusions. Which are our take-home points? Well, Chagas disease is caused by the protozoan Trypanosoma cruzi, acquired primarily through vector-borne transmission. CD can present with complications in both acute and chronic phases. So in the terminal phase, chronic Chagas myocarditis results in extensive myocardial fibrosis, also chamber enlargement, and aneurysms, which our patient didn't have, but he did have ventricular tachycardia. So cardiac MR has been useful in demonstrating the extent and characteristic of myocardial involvement in Chagas disease, mainly being represented by this late enhancement with gadolinium as a sign of fibrosis. So these are my references, and thank you very much.
Now we have Dr. Sofia Gambetta from Hospital Universitario Austral in Argentina. She's going to present a pulmonary hydatid cyst.
Hello, my name is Sofia Gambetta. I'm a radiology resident at Hospital Universitario Austral, Buenos Aires, Argentina, and today I'm presenting a clinical case that I was involved, and I'm excited to share our findings and outcomes with you. It's about a 57-year-old male from a rural area who worked with livestock and with clinical history of hypertension and heavy smoking. He presented to our institution with productive cough of 2 months duration and fever of 5 days duration. He also referred receiving antibiotic treatment for a week at a primary medical care center without clinical improvement. Physical examination note decreased auscultation in the left lung. Laboratory findings showed a slight increase in white blood cell count and negative HIV serology. The first X-ray showed a non-specific nodular image in the left lower lung parenchyma. The coronal chest computer tomography scan revealed a 38 by 34 millimeter cavitated nodular lesion in the left lower lobe with 5 millimeter wall thickness. The mediastinal window of the CT also revealed left pleural effusion. The follow-up CT, which was 3 weeks later, showed a slight decrease in the site of the lesion, absence of cavitation, and no evidence of pleural effusion. So, the radiological findings associated with clinical and epidemiological context led to the consideration of pulmonary hydatidosis as the main diagnosis. However, because of the smoking history, lung cancer was considered too. The initial treatment consisted of albendazole for 3 months, but the treatment was not complete due to financial limitation of the patient. The persistence of symptoms led to the decision to perform surgical intervention. Here I show some of the histopathological findings obtained during the surgery, which we can see infiltration of lymphocytes and granulomatous reaction in response of the presence of a microorganism. The patient evolved favorably and was discharged 5 days after the surgery. But considering that the causative agent of pulmonary hydatidosis in this case was transmitted directly from non-devoured animals, our institution contacted the primary medical care center in the rural area where the patient came from in order to promote prevention and reduce cases of hydatidosis in the area. So, the take-home points are: hydatid cyst caused by the larval form of Echinococcus is a zoonosis of worldwide expansion, endemic in South America, working closely with farm animals and poor health infrastructure. Lungs and liver are the most common organs involved, and uncomplicated hydatid cysts of the lungs are usually asymptomatic, while complicated cysts present with non-specific clinical features like coughing, chest pain, and hemoptysis. Imaging, especially CT, plays an essential role not only of the diagnosis but also in the visualization of the extent of involvement and complications. Those are the reference. Thank you very much. Hello.
Okay, now we have Dr. Galo Pillajozulca. He is from Medinuclear in Ecuador. He's going to present malformation of cortical development.
Hi, my name is Galo Pillajozulca. I have completed the 4th year of postgraduate studies in diagnostic radiology at the Universidad Central del Ecuador. Today, I will be presenting a clinical case titled Cortical Developmental Malformation from a Different Approach. This case was acquired at the Medinuclear Radiology Center in Quito, Ecuador. The authors declared that we have no competing interest. We have a 5-year-old child who presents with drug-resistant epilepsy and developmental delays. Past medical history includes birth via cesarean sections at 36 weeks due to the oligohydramnios and fetal bradycardia. Physical examination shows microcephaly and generalized hypotonia. A conventional MRI study was performed, which revealed a decreased head circumference for age, few and shallow brain gyri, associated with a simplification of the suicide pattern, thickening of the cerebral cortex, and compensatory dilatation of the ventricles. Also, we can notice a cerebellar hypoplasia. It is worth noting that the corpus callosum is present, and no additional intracranial lesions were observed. With this finding, the final diagnosis was lissencephaly. However, we ask ourselves the following question. Is there a way to quantify the structural changes in this case? Our answer was in advanced neuroimaging methods. So, for MRI brain segmentation, we analyzed it using the BoldBrain platform. Even though the BoldBrain platform wasn't developed for these cases, its results were pretty good. The results support the finding of microcephaly with a brain volume of 739 cc. The gray matter is preserved relative to the reference values for age, both in the cerebral cortex and the basal nuclei. On the other hand, the white matter presents a notable decrease in volume. The second method was tractography. With tractography, it was demonstrated that projection fibers, such as the corticospinal tract, preserve the fiber volume and spatial distribution. This finding is clearly visible when comparing our patient with an age-matched control. In the patient with lissencephaly, the corpus callosum has a smaller volume and is composed of fewer fibers. We perform an analysis of association fibers, taking as an example of the language pathways. In the first row, we can observe a comparison between the dorsal stream in the patient with lissencephaly and the control, small in our patients. In the lower row, we observe the white matter tracts that make up the ventral stream, such as the oncidial fascicle and the inferior fronto-occipital fascicle, which are decreased in size. Based on the data obtained in tractography, we obtained connectograms for both our patient and the control. We can observe how, in our patient, there is an asymmetry in connectivity, with a notable decrease in homolateral association fibers. Likewise, we know that there is an important reinforcement on the fibers that communicate the limbic with the frontal cortex. After that, we conducted a connectivity analysis, where we can observe an asymmetry between the connection of the cerebral lobes, with a predominance in communications between the temporal, frontal, and limbic regions. In the healthy control, we can observe important communication between the frontal lobes. In conclusion, patients with lissencephaly have preserved gray matter volume, both in the basal nuclei and the cerebral cortex. The cerebral white matter is decreased, affecting especially the commissural fibers and the association fibers, but preserving the projection fibers. Lissencephaly presents an altered pattern in the connectogram relative to the control. In the future, this type of analysis will allow us to predict failures of different cerebral systems based on morphological changes, information that will enable us to develop the specific treatments for each patient. As a final point, I invite you to visualize an interactive 3D model of our patient with lissencephaly and their different white matter tracts. We developed this model using conventional MRI, brain segmentation, and tractography. You can try this model on a computer or cell phone by scanning the QR code. Thank you very much for your time and attention.
Next, we have Dr. Ileana Persot from Guyana. She's from Georgetown Public Hospital Corporation, and she will present the case of disseminated pulmonary tuberculosis.
Hello, my name is Ileana Persad. I am a second-year radiology resident at the Georgetown Public Hospital Corporation in Guyana. My mentor is Dr. Jessica Lishid. Other team members include Dr. Samantha Singh, Dr. Anastasia Daniram, and Dr. Angelita Su. I have no disclosures. The title of my case presentation is Disseminated Pulmonary Tuberculosis in a Pediatric Patient. History: 4-year-old child referred from an outlying healthcare facility with a history of fever, shortness of breath, and enlarged cervical lymph nodes for more than 1 month. Past medical history: admitted to the Georgetown Public Hospital Corporation in June 2022 for complicated pneumonia and symptomatic anemia. Vivax malaria in April 2022. Social history hails from the village of Paramita in Guyana, near the Venezuela border, and lives in a PENAP with a family of 4 people. Figure 1 shows a typical PENAP used for housing in Paramita. Physical examination. Heart rate and respiration rate were increased at 124 and 42 respectively. Labs, white blood cell count was in 14,000, HB 6.4, and AFP was positive. Physical exam, mucus and membranes, pale and icteric, respiratory system, harsh breath sounds bilaterally, marked nasal flaring, intercostal and supraclavicular retractions, use of accessory muscles of respiration with a respiration rate of 42. Extremities were cold to touch with non-pitting edema. Lymph, numerous enlarged, palpable, and non-tender lymph nodes in the cervical region. Imaging findings. Posterior anterior chest X-ray demonstrates patchy airspace opacities in bilateral upper lobes, right perihilar region and base, with blunting of the right costophrenic angle. CT coronal view of the neck. Coronal image from a non-contrast CT of the neck and chest showing innumerable enlarged cervical and supraclavicular chin lymph nodes, indicated by the arrow on the right. Coronal contrast enhanced CT of the chest demonstrates pleural fluid with rim enhancing loculated pleural base collections representing abscesses, indicated by the arrows. Axial CT of the chest in the lung algorithm shows extensive perihilar consolidations with air bronchograms with cavitary lesions measuring less than 1 cm seen in both upper lobes. Axial CT of the chest in lung algorithm also shows innumerable sub-centimeter solid pulmonary nodules distributed throughout both lung fields. Contrast enhanced axial CT of the abdomen demonstrates multiple enlarged retroperitoneal and mesenteric lymph nodes. Largest is 11 mm in short axis, some of which have necrotic components. Small volume of ascites noted. Course of disease and treatment. Diagnosis was confirmed with AFP tests. Patient was subsequently transferred to the infectious hospital and started treatment. The usual treatment of pulmonary TB is a 6-month course of a combination of antibiotics, which include isoniazid and rifampicin for 6 months and 2 additional antibiotics for the first 2 months of the 6-month period. Discussion. Infants and younger children are more likely to develop life-threatening forms of TB disease, which include disseminated TB and TB meningitis. In this case, apart from age, anemia also contributed to his susceptibility. My references are as below. Thank you.
Now we're going to proceed with Dr. Sebastián Gallo Bernal from La Cardio in Colombia. He's going to present a case titled A Broken Heart.
Hello, everyone. Thank you so much for having me on today. It's a real honor to share this session with you. My name is Sebastián Gallo, and today I'll be presenting a fascinating and unique case titled A Broken Heart, Bleeding Ventricular Cutaneous Fistula after a traumatic dissection of the LAD, acute coronary syndrome, and secondary infected ventricular pseudoaneurysm. So this is the case of a 44-year-old male, status postmedial sternotomy, who presented to the ER with a 2-month history of a sanguineous discharge from his medial sternotomy scar. Associated with this, the patient referred chest pain as well as shortness of breath. Our patient's previous history is very important to understand this case. 2 years prior to the current visit, the patient was admitted after sustaining multiple stab wounds to the anterior aspect of the chest. At that time, the patient was in shock and was directly directed to the OR. An urgent medial sternotomy was performed and 3 epicardial wounds in the anterior aspect of the left ventricle were noticed, one of which was actively bleeding. The epicardial wounds were immediately repaired and hemostasis was achieved. After this, the patient's vitals transitorily improved. However, about 12 hours after the initial intervention, the patient developed severe cardiogenic shock, which was refractory to both medical therapy and supportive measures. Suspecting an associated coronary injury, the patient was taken to angiography, which showed occlusion of the mid portion of the LAD, as well as severe hypokinesis of the whole left ventricle. Several attempts to reestablish flow percutaneously were unsuccessful, and surgical revascularization was planned. However, the patient acutely and severely decompensated, and a purulent discharge was noticed from the sternotomy wound. A computed tomography at the time showed a huge mediastinal abscess, and the patient underwent several rounds of local wound debridement as well as external wire removal. Cultures from secretions at that time were positive for Candida glabrata as well as Enterococcus faecalis. The patient was treated with a long course of antibiotics, the infection resolved, and he was discharged. However, we lost follow-up until the current visit. So on current admission, physical examination was positive for conjunctival pallor. There was a 13-centimeter keloid scar at the site of the previous sternotomy. We saw 2 ulcerations, one on the superior and other on the medial aspect of the lesion, both of which were active and pulsatile bleeding. On cardiac examination, there was a regular rate and rhythm with a normal S1 and normal S2. However, we saw and we found a pansystolic murmur at the level of the right upper sternal border. Here we have the results of the initial labs of our patient. He was anemic, his creatinine was a little bit high, his troponin was high, positive, and the EKG on admission showed necrosis of the anterior wall of the left ventricle. Right here we have the actual images of a chest CT at the level of the lung window showing a huge chest wall defect as well as disruption of the mediastinal and epicardial fat. Cardiac MRI was ordered to better characterize cardiac function and anatomy. Right here on the actual plane, on the fluid sensitive or bright blood sequences, we can see disruption of the epicardial and mediastinal fat. We also can see right here a saccular structure of about 30 millimeters in diameter, consistent with a left ventricular pseudoaneurysm. In addition, we can see a communication, a fistula between the left ventricle and the chest wall. If we go closer to the diaphragm, we can see an additional fistula, an additional communication between the left ventricle and the chest wall. Here we have an image on the 2-chamber view of the CNA images. Again, we can see a huge saccular structure, a pseudoaneurysm on the anterior wall of the left ventricle. In addition to these, we saw severe segmental wall motion abnormalities at the level of the territory irrigated by the LAD, which were consistent with the history of a previous myocardial infarction. Right here, we have the late gadolinium enhancement images. We can see severe inflammatory changes as well as fibrotic changes of the anterior mediastinum. We can also see a hypointense thrombi right here on the inside the pseudoaneurysm, as well as a couple of thrombus right here on the apex of the heart. Right here, we have a summary of all the imaging findings of our patients, imaging findings which were confirmed during surgery. The patient underwent repair of the pseudoaneurysm as well as the 2 fistulas. 2 months later, the patient's symptoms significantly improved and cardiac rehabilitation was initiated. We hypothesized that a severe infection next to the ischemic pseudoaneurysm, which was caused by the traumatic dissection of the LAD, conditioned the onset of this ventricular cutaneous fistula. As a take-home point, this case illustrates the utility of cardiac MRI in the assessment and surgical planning of patients with complex cardiac pathology. Thank you so much.
Thank you so much for staying with us. We presented 16 cases and we have 4 more to go. Please remember that at the end of the 20 presentations, we're going to have the voting for the People's Choice Award. So please keep staying with us and enjoying all the cases. Next up, we have Dr. Gerardo Barrientos from Instituto Guatemalteco de Seguridad Social in Guatemala. He's going to present a case on complete urinary bladder duplication.
Good morning, everyone. My name is Gerardo Barrientos, and I'm currently a third-year radiology resident at Instituto Guatemalteco de Seguridad Social in Guatemala. Today, I'll be presenting a rare case of complete urinary bladder duplication and other congenital abnormalities. Before I start, I would like to thank the Departments of Radiology at Penn Medicine, the Children's Hospital of Philadelphia, and the Perelman School of Medicine Center for Global Health for this opportunity. I would like to add that I have no conflicts to disclose. To get started, we have a 26-day-old girl who presents to the pediatrics department for further evaluation of an anorectal malformation detected at birth. On examination, she presents with an enlarged clitoris, urethra shifted to the left side, a central vaginal canal with a septum that divides into two cavities. The one on the left is a blind sac and the right one is the vagina, and a rectal fistula on the right side. Furthermore, she presents with a rudimentary anus with irregular borders and a functional sphincter. She was born at term at a rural hospital in Salamá, Baja Verapaz. She was a firstborn, and the mother had a normal pregnancy with no significant medical history. An intravenous urography was performed where the AP view at 8 minutes reveals contrast in the left renal pelvis and in the bladder, which presents a central sagittal septum with two necks. This confirms a complete bladder duplication. On the 15-minute AP film, the bladder duplication with both urethras can be identified along with the insertion of a lower left urethra on the left bladder. The 32 film shows in better detail that the upper right urethra has no abnormality as well as the middle left urethra. The bladder shows contrast residue post-urination with the persistence of the septum. This is the fistulagram in which a catheter was placed through the fistula, and we were able to see how the contrast passes to the rectum and sigmoid colon. Another catheter was placed in the rudimentary anus to evaluate permeability. Contrast passes without any inconvenience to the rectum and sigmoid colon. We can differentiate this image from the previous one by observing the presence of the anal sphincter. Due to the magnitude and the odd nature of the case, the management and treatment is still being discussed among the pediatrics, surgical, and urology teams, with the main goal being reducing the chances of any complications like UTIs. The expected treatment is the closure of the fistula and evaluating the clinical implications of the bladder duplication to consider which option benefits the patient. Considering Guatemala is a third world country in which antenatal and postnatal care is limited, the initial neonatal evaluation is critical in identifying congenital abnormalities. The detection of these malformations on the physical exam and further characterization throughout radiology examinations allow the physicians to determine the proper treatment. Limited resources and sparse access to technology make a thorough assessment difficult. However, in these cases, plain X-rays enhanced with contrast become more valuable and a key diagnostic tool. These were the references used. Thank you very much.
Okay, now we have Dr. Mario Cinti Icochea from the Instituto Nacional de Salud del Niño San Borja in Peru. He's going to present type 2A biliary atresia.
Good morning to everyone. My name is Mario Cinti Icochea, medical resident of radiology from Lima, Peru, presenting the case of type 2A biliary atresia in a child with Langerhans-Sells histiocytosis. We don't have any conflict of interest to declare. We present the case of a 6-month-old female from urban marginal setting in Lima and past medical history of neonatal jaundice that started 7 days after birth. as well as a cytomegalovirus infection, probably prenatal asymptomatic diagnosis. But the mother referred that the child had also been diagnosed with Langerhans cell histiocytosis by a skin biopsy performed in another institution due to lesions that appear in her back, characterized by reddish-brown macule papules and eczematous lesions. This is a referential image taken from this article here below that shows lesions to what our patient, similar lesions to what our patient previously had, according to her mother. Our patient arrived at the emergency room with 1-day onset of fever, water stools, abdominal pain, seizures lasting less than 1 minute. An hour before arrival, the patient lost consciousness after a status epilepticus episode and was admitted for hospitalization. Remarkable lab results were cholestatic pattern in the liver panel and mildly elevated white blood cells with left shift deviation characterized by 10% band neutrophils. Also, anemia and low platelets were found. During hospitalization, an abdominal ultrasound was performed and showed evidence of chronic liver disease characterized by irregular liver contours, as seen in this picture, also a moderate amount of fluid, and in a small and irregularly shaped gallbladder. On Doppler ultrasound, we saw subcapsular arterial signal flow, which is an indirect sign of biliary atresia. So we went for an intraoperative cholangiogram showing lack of representation of the common bile duct, as I'm pointing in here, and also intrahepatic ducts were not represented. A very thin caliber common bile duct was represented here, as I'm pointing it, and an irregularly shaped gallbladder previously seen in the ultrasound tube. So because of these findings, our initial diagnosis was a biliary atresia Kasai type 2A. A contrast enhanced CT was also performed to look for histiocytic infiltration in other organs. We did not find any systemic infiltration in thorax or abdomen, but we noticed these perivascular cystic lesions seen in the blue arrows, which were considered as biliary lakes in accordance with biliary atresia. So our big question here was, those perivascular cystic lesions were bilakes in accordance with biliary atresia, or considering that the patient have already had LCH, those cystic lesions were histiocytic infiltration. So a liver biopsy was performed with negative results for histiocytic infiltration of LCH, so our department of radiology recommended to perform an MRI. Now, due to the moderate amount of ascites and movement artifacts, we could not represent very well the MIP reconstruction of the MRCP, but we can show you the axial images of the volumetric acquisition, which demonstrate the cystic dilation of the biliary tree here as I'm pointing it, and also represented within the contrast enhanced images here at the site, which is consistent with sclerosing cholangitis, probably due to immune mechanisms because of the lack of histiocytic cells in the biopsy. We have to mention that the cholangiogram showed evidence of biliary atresia, but sclerosing cholangitis, because of these MRI findings, was also to consider an additional diagnosis due to these findings. So hepatic cirrhosis in children is a common cause of liver transplantation. LCH is an uncommon cause of chronic hepatopathy, and one of the complications is sclerosing cholangitis by 2 mechanisms of liver involvement, which should be taken into account. After many multidisciplinary reunions with different specialists, we concluded that the causes of the biliary obstruction seen in the liver are biliary atresia and also an sclerosing cholangitis due to the immunomediated mechanisms by imaging findings. Our patient is still delicate and has a poor prognosis. LFTs are still raising, so chemotherapy might jeopardize the patient's outcome, according to the onco team. She is currently still in our hospital waiting for a response of a foreigner hospital for a possible liver transplant without administering chemotherapy previous to the surgical procedure. So we present this case to also encourage to do more research on these pathologies because there is not sufficient data until the moment. These are my references, and thank you for your attention.
Okay, now we are down to 2 more cases. The next case is going to be presented by Dr. Andrés Aro from the Hospital Metropolitano del Ecuador in Ecuador. He's going to present juvenile nasopharyngeal angiofibroma.
Good morning, my name is Andrés Aro. I'm a 4-year resident of radiology in Quito, Ecuador. Thank you for letting me present my case. It's called juvenile angiofibroma. I have no disclosures. So we have a 14 years old male patient with no significant clinical or pathological history, not known allergies, and he's from Yangana, Ecuador, a small town in the south of my country. It's about 10 hours from the capital city, Quito, and is an indigenous town with a lot of lack of access to educational and health systems. So this patient presents with 1 year of epistaxis and nasal obstruction. He went to a particular doctor who made a rhinoscopy and saw a mass in the left nasal cavity. So due to the inability to resolve this problem, he went to Quito, where through a non-profit organization, he was referred to our hospital. In our hospital, we perform a computer tomography with a contrast administration. We can see this axial image where the red arrow point as a mass with evidence of the contrast in the left nasal cavity, filling this place and extending into the nasopharynx. We presume that this mass origin is in the sphenopalatine foramen. In this coronal image, the red arrow showing us that this mass is extending towards the floor of the left sphenoid sinus. And in this sagittal image, we can see how big is this mass and is producing severe stenosis of the airway. And also we can see how is an inferior displacement of the soft palate. This last image is a volumetric reconstruction of the mass where we can see its relationships of the tumor with the adjacent structures. So with this characteristical image, we made a diagnosis of juvenile angiofibroma, called previously juvenile nasopharyngeal angiofibroma, but is more correct the first term because this tumor begins in the nasal cavity and not in the nasopharynx. So this patient went through angiography with embolization. This image is a subtraction of this angiography where the red arrow is showing us this tumor and how the source of irrigation of the tumor is the external carotid artery, especially the internal maxillary artery. So we made an embolization and exclude 90% of the irrigation of the tumor. This is an image post-embolization where we can see how is not present this tumor anymore. So take-home points are that this tumor is highly vascular neoplasm. This is more frequent in males between 10 and 25 years old. Even though it's a benign tumor, it has a lot of invasive behavior, and the cause remains unclear. However, the WNT pathway, angiogenic, and hormonal factors are involved in the pathogenesis of this mass. Also, we have to know that this origin is in the sphenopalatine foramen, centered in the posterior wall of the nasal cavity, and this in place led the tumor to spread or go into the pterygopalatine fossa in 90%. Also to the sphenoid sinus extension, it may go to the ethmoid sinus, or even in 20% goes to the mild carinal fossa by the Vidian canal or the foramen rotundo. So thank you very much for your attention.
Okay, now the last case is from Dr. Noely Larios from the Universidad Nacional Autónoma de Honduras. In Honduras, she's going to present a case on pericardial thickening.
Good morning, my name is Noely Larios. I'm from Honduras, Central America, and today I'm going to present an unusual cause of pericardial thickening, a case report. Our patient is a 64-year-old male prisoner in Honduras with history of fever, chest pain, and dyspnea. He has no history of chronic disease or immunodeficiencies. On the physical exam, there were no obvious focus of infection. The patient was transferred to a hospital unit for inpatient evaluation and further investigation. General labs were performed with unremarkable results, including an HIV negative serology. Given the social history as a prisoner in Honduras, a broader differential diagnosis was considered and imaging was performed. Here we can see the chest CT, long window, axial, and coronal reconstructions where we can appreciate diffuse bronchial wall thickening, a peribronchiovascular consolidation in the right upper lobe, scattered centrilobular nodules, periseptal thickening, mild bilateral pleural effusion with some fissural component. And in this axial non-enhanced CT medicinal window, we can appreciate the extensive pericardial nodular thickening with some areas of hyperdensity which may reflect a complex fluid and calcifications. With these non-specific imaging findings, multiple labs were performed, including specific testing for TB. In this case, they were negative since the first week until the day 24th, where a GeneXpert test was positive for MTB. In my country, TB is always a first, second, and third choice until proven otherwise. This was not a typical case of TB, since there were no lymphadenopathies, no tree-in-butt nodularity, no cavities, and no granulomas to suggest a prior inactive TB. Our approach to nodular pericardial thickening on imaging is very narrow, and it's going to vary depending on the patient's demographics and risk factors. Although in our population TB is common, pericardial primary involvement remains unusual, and it's mostly associated as a complication of pulmonary TB with a prevalence of 1%. Other differential diagnoses are primary pericardial tumors, which are rare, and cardiac metastases or secondary cardiac involvement by non-Hodgkin lymphoma. I'm going to end the presentation with the take-home points. Infectious disease can have an atypical presentation mimicking tumoral disease. It should always be considered as a differential diagnosis in TB endemic areas. It is our responsibility as radiologists to suspect and raise the possibility of pericardial and pleural TB, even with negative lab results in the proper scenario. Thank you very much.
These were all great cases. Now we're going to give you 10 minutes so that you can vote for the People's Choice Award while the judges deliberate for the winners of today's case competition.
Hello. It's been a tough process. Thankfully, we have veterans like Hansel over here to guide us through this. Yeah.
No, first, we'll get to the winners, I promise. But again, congratulations on everyone that made it. The level for the presentations this time around. Like, I personally not only impressed. I want to take notes of all the great little tips for presentations that you guys included. You know, like from the transitions and how to present the images. It was very high level. So I want to congratulate everyone for participating. I again want to take the 1 second to say thank you to all our colleagues that help us spread the word. And we have one piece of homework for you. Like if you've been in this case competition, please make sure that you let your programs know that you were here. Please help us spread the word. We're going to see you back in 1 year. And we really would like to have all the same programs participate and add more. So please also tell your junior residents to send their cases, and we'll make sure that we are here next year. Also, in that same note, to thank our leadership, like the departmental leadership from Penn Radiology and CHOP, because they are supporting us. Like, we are here with a growing team that is supported by leadership, and they also allow us to give prizes. So with that being said, I think that we should just announce the winners, right?
We have to, yeah, that's why the people are here.
We start with which one do you want to start?
We can start with the People's Choice, right?
Okay.
We had no control of this. I mean, this is the voice of the people. I do the honors. The winner of the People's Choice.
Oh, Mohammed is showing like the entire slides instead of the slideshow. Is that true, or is only for us? All right. Let's try that again. Go ahead.
Right, so that's right.
Yeah.
So the winner of the People's Choice is Dr. Maria Andrea Buzzi, glial heterotopia in a newborn from Argentina. And Dr. Maria gets $250 for her troubles.
All right, and then we move straight up to the third place winner. And for our third place, we have a great presentation by Dr. Jennifer Richardson from Colombia, atypical hepatic mesenchymal hamartoma. Thank you, Jennifer. Congratulations.
Moving on to second place, this is a great presentation as well. Things definitely got harder to choose as we get higher, but I think we all agreed that Dr. Rodolfo Lourenco's presentation on recurrent respiratory papillomatosis from Brazil was worthy of second place.
All right, and now for the big win. We have, again, one of the countries that chose to participate this time around, and we're happy to see more and more of, Dr. Francisca Aliaga from Chile, left ventricular apical hypoplasia. Very unusual case, great presentation, and congratulations.
So yes, so there you have it. Again, this is a great time. As you can see from the camera, we have a great crew of people. We're having a blast. We do this here at the CHOP Roberts Research Building, a great place to be. Our next case competition will be in about 3 months, focused on Africa and the Middle East. So stay tuned. It's nice to be able to meet your colleagues from different regions of the world. So we're excited. Like Hansel said, this wouldn't be possible without the folks in the room, without our support from leadership. You know, my chair, Mitch Schnall, Casa Darge, they've supported us from the beginning. So thank you so much for spending the early hours of your Saturday with us today, and see you next time.
Yeah, see you soon. Gracias por participar y felicitaciones a los ganadores. Hasta luego. Chao. Bye. Oh, no, sí, no se vaya. Esta es la encuesta de feedback. So this is your evaluation of the program. Please fill it up. Let us know if we can do anything better, and how to improve. What parts did you enjoy and what parts we can do better. So this will stay for a second. We'll go back to sharing some music, and then we'll be intermittently also projecting the winners, just so it's clear to everybody, or for those of you that step away from your computer just at the wrong time. All right. So thank you very much. Have a good one.